Hello, everyone. I'm Marsha Mott, and welcome to UF Health Wellness University. I'd like to thank you for joining us at our webinar today as we discuss a very popular topic, neuropathy. I'd like to introduce you to our speaker, Dr. Miguel Chuquilin. Dr. Chuquilin joined the neurology faculty at the University of Florida in 2016. He's board certified in neurology, neuromuscular medicine, and electrodiagnostic medicine. He's also a member of the American Association of Neuromuscular and Electrodiagnostic Medicine Physicians. If you have any questions for our speaker, you can submit written questions at any time using the Q&A button at the bottom of your screen. At the end of the presentation, I'll read your question anonymously. I will only be accepting written questions today. We have a lot of people attending, so I'm going to try to get to as many questions as possible, but we might not be able to get to every question. I'm going to do something today. I'm going to ask you to complete a poll. I'm going to launch a poll at the bottom of your screen in a second. And I want to know where you're watching from. I want to know where you guys are located and where you guys are joining us from, because it's kind of interesting to see where everybody's from. And I'll let you guys know those answers in a few minutes, okay? So while we're getting that settled, Dr. Chuquilin, I'm going to go ahead and turn it over to you right now, okay? Thank you.
Thank you. Thank you, Marsha. Well, thank you for inviting me to do this webinar about peripheral neuropathy. Always an interesting topic to discuss about. I'm one of the neuromuscular faculty here at UF. I've been here about 5 years, and I'm very interested in all neuromuscular diseases, especially peripheral neuropathy. So let's start with some definitions first, okay? So what is peripheral neuropathy? In medical terms, we use the name neuropathy to call any nerve damage. So you have any sort of nerve damage, including carpal tunnel, that's a type of neuropathy. Now, when patients come to see me or go to see a physician, what they mean by neuropathy is really numbness or tingling in the feet. Usually that's the length-dependent type of neuropathy, the most common type of neuropathy, like people with diabetes usually experience. But like I say, in general, we call neuropathy anything, but the most common type is going to be the one that starts in the toes and the feet and it slowly moves upwards. So it can affect really any nerve in any part of the body. We have nerves everywhere. There are different types of nerves. So we have sensory nerves that are responsible for sensations such as temperature, pain, vibration, and something we call joint position sense or proprioception. We have motor nerves that basically control the muscle. You know, they're responsible for making the muscles move.
Hey, I'm sorry to interrupt, but we don't see your screen share right now. We just see you.
Oh,
so why don't you launch your screen share again?
Okay, I think you stop screen share. Okay, let's do this again. Okay, can you see it again?
Yes, we do. Perfect. Thank you.
All right. Yeah. So peripheral neuropathy, like I say, in medical terms, is any nerve damage. Can affect any nerve in any part of the body. We have different types of nerves, sensory nerves responsible for different types of sensations, such as temperature, pain, vibration, or joint position sense. Motor nerves are the nerves that control our muscles that allow us to move. And autonomic nerves are more those responsible for automatic functions in our body. So for example, blood pressure, heart rate, digestion, bladder, urination, reflex, saliva, and lacrimation, so tearing. And the symptoms really depend on what the type of the nerve is affected. You have more the sensory nerve involvement, you're going to have more numbness, tingling, pain, or sensory functions being affected. If you have motor nerves involved, you're going to have weakness, muscle atrophy. If you have an autonomic neuropathy, autonomic nerves being affected, then maybe blood pressure fluctuations, lack of sweating, lack of tears, a dry mouth, gastroparesis, slow GI motility. It can be a combination of all of them as well. Okay, so in general, again, peripheral neuropathy is very common. About maybe an estimate of 20 million people have neuropathy at some point in the US. This represents close to 7% of the general population, can affect 8% of people over 55 years of age. It's really, if you take all the neuropathies into account, it's going to be the most common neuromuscular disorder. If we bundle all together, all different causes, yes, it becomes really common. And especially because of due to the prevalence of diabetes. A lot of patients have diabetes. About 107 million of non-Americans in the US will have diabetes, and up to 70% of them will develop neuropathy. So that accounts for a large part of the neuropathy we see in clinic or in primary care clinics as well. So again, for most people, the neuropathy is gonna start in the toes or in the feet. This is what we call the length-dependent neuropathy. So initially will affect the longest nerves in our body. So if we think about this, I have a little diagram here, very simplistic, but it kind of illustrates the point. This is our brain, this is spinal cord here, and the nerves coming out, from the spinal cord, different parts going to your face, or the cranial nerve area, going to the arms, the thorax, and also the lower extremities. So if we try to identify the longest nerves in our body, they're gonna be the ones going to the lower extremities, okay? Because they start kind of in the lower back area and the lumbar area, going all the way down to your toes. So that's the longest nerve. And people with length-dependent neuropathy, such as diabetes, for example, diabetic neuropathy, these longest nerves are gonna be the ones affected first. So these patients will present with numbness, tingling, or pain, or different sensation abnormalities in the toes initially. Then this will slowly, move upwards as the disease progresses. And by the time it gets about, knee level, it will start affecting the fingers as well, okay? So it will seem to skip the rest, but it's not skipping anything, it's just affecting the longest nerve. So by the time it gets to the knees, the distance from the spinal cord to your fingers is about similar to the distance from the lower back to the knees. So it's starting to affect the longest nerves at that time, which is gonna be the fingers, and slowly move up. And patients with severe, very severe cases, untreated for many years, and this is rare, but it can happen. It can also start affecting the anterior abdominal area, like a shield in the belly, because those nerves at that point, by distance from the spinal cord, are also the longest nerves at that time. So it can spread very slowly, usually with many years, but you have different causes, like inflammation causes or other type of etiologies. The progression can be a little faster too. So this type of pattern is called length-dependent pattern, or most commonly also known as stocking and glove distribution, because it seems that you have stockings and gloves in your feet and your hands. Most people with neuropathy are going to be above 55 years of age again. Now, in terms of symptoms, sensory symptoms are the most common symptoms in neuropathy, and sensory symptoms can be classified different ways. The most, I guess, useful way of classifying them is positive and negative symptoms. Positive symptoms are secondary to nerve misfiring. So really, the nerve shouldn't be activated. It shouldn't make you feel something, but it's making you feel that because it's misfiring, it's damaged. So it starts fighting when it's not supposed to. So you have a lot of positive sensory feelings in terms of like pain, for example, tingling, burning sensation, pain with a stimulus that normally doesn't cause pain. That is called allodynia. It's a medical term. But basically, somebody touches, your fingers or your toes or your feet, and it feels extremely painful, even though it was a very gentle touch. They can have sensitivity to touch, cold or hot sensation when it's not hot or cold. It just feels like that. So you can have different descriptions. We always ask the patients to describe the symptoms during the visit. And the intensity can vary. It can be very intense, 10/10 intensity, or 2, 3/10 intensity. It can fluctuate over time as well. Negative symptoms are basically lack of function of the nerve. Okay, and people are sometimes unaware of them because they're not bothered by them. They don't know they're numb unless somebody tests the sensation on their feet, for example. And they go to the clinic, to the primary doctor, or the endocrinologist, or even the neurologist for a different reason, and they get a physical exam and they find out they don't have a good sensation in the feet, so they may actually have some sort of neuropathy they were not aware of. So numbness, lack of feeling, and have poor balance. This is in neuropathy can be secondary to poor position sense. So our joints have receptors in them that allow us to sense position of our body and space. So if those receptors are damaged, those are sensory receptors. If those receptors are damaged secondary to this neuropathy, and they don't sense the position in your body in space. So when you close your eyes, you may lose your balance, for example, because you don't know where you are. Lack of coordination and falls can be a symptom as well. Muscle weakness, obviously lack of motor nerve function will lead to weakness and muscle atrophy, loss of muscle mass. And other symptoms, and in this case, secondary to involvement, usually of autonomic. So these nerves that control automatic functions in our body. Heat intolerance, for example, altered sweating, usually lack of sweating. When you're supposed to sweat, so people can overheat easily, especially here in Florida. Erectile dysfunction. This can also have vascular causes, obviously. Blood pressure drops, especially, for example, getting up from sitting position or very early in the morning when you go to the restroom, for example, and fainting. That is called orthostatic hypotension, so blood pressure drops. Dizziness, lightheadedness. There can be increased risk of ulcers or infections in the feet. One, because you don't feel when you have injuries in your toes or in your feet. For example, people with diabetic foot, and also for due to lack of circulation. So what is the progression of neuropathies? And this is a generic term, there's different etiologies, but most neuropathies will progress slowly, okay? I say most because diabetes is the most common one, and it progresses over time, over usually many years period, especially with the diabetes continues to be uncontrolled. However, some types can progress rapidly and start rapidly and progress from there. One such neuropathy is GBS, or Guillain-Barré syndrome. This is an autoimmune neuropathy that usually progresses over a period of 4 weeks, and then kind of stops progressing, but it can leave you with some disability, depending on how severe it was during those first 4 weeks. And the other neuropathies in between. When we see patients with neuropathy in the clinic, we always try to make sure we're not missing some rapidly progressive neuropathy. And etiologies for those include inflammation in the nerves, what we call vasculitis, and also some other autoimmune diseases. One of them is called CIDP. Other causes of neuropathies, even more rare, are nerve infiltration by tumoral cells, cancer. Chemotherapy neuropathy is another cause. We can see that, especially in patients obviously can receive chemotherapy agents. That's usually secondary to the chemotherapy being neurotoxic. And then it's one hit, but then it can continue to progress over time, over a few months, even after stopping the chemotherapy. But it won't progress indefinitely. It will, at some point, will stop, but it can, even after you receive chemotherapy, the next 6 to 12 months could continue to progress. Now, other classification of neuropathy can be done by type of nerve fiber, okay? Like I said, we have sensory neuropathies affecting sensory nerve fibers, motor neuropathies, autonomic neuropathies, and mixed neuropathies, meaning combination of those 3. By the part of the nerve being affected. So if we think of the nerve, it can be thought of as electric copper wire, okay? You imagine an electric copper wire, it has the copper metal inside. That is called the axon here. That will be the copper part of the electric wire. And then it has something called a myelin sheath, which is this here. That will represent the insulation in your copper wire, electric wire. That's the insulation, okay, the plastic part, plastic coating. So if you have damage to the axonal part, so the copper wire itself is called axonal neuropathy. Those are usually more severe because the axon is a part that comes directly from the nerve cell itself, in the spinal cord or next to the spinal cord. So if the axon is damaged, it dies off. And then you recover of the neuropathy. Let's say we find the cause and we treat it and we fix it. You will still have deficits because those axons have to grow back from the nerve cell itself, either in the spinal cord or next to the spinal cord where they are located. They have to grow back and go where they're supposed to go. If you imagine, the most common types of neuropathies start in the toes and the feet. So it has to go from your spinal cord or next to it, all the way down your leg to your toes. And, it's a long distance. So it may not get there on time, and it just take a while, usually months to years, depending on how long you have the neuropathy. Demyelinating neuropathies, or neuropathies that affect the insulation of the nerve, so the plastic coating of the nerve, those are more easily to be treated with immunomodulating agents such as IVIG or steroids and things like that. And they can recover a little faster than axonal neuropathies because myelin sheath is not part of the nerve cell, is produced by a different type of cell and can be synthesized faster. So prognosis may be a little better depending. And if you have demyelinating neuropathy that is being untreated for some certain type of period, it can also lead to axonal loss eventually. So we have patients with demyelinating neuropathy that has been undiagnosed for a long time, then they almost all of them will have axonal loss. So the nerve itself is damaged, and the prognosis obviously is worse at that time. And there can be neuropathies that are mixed, so affecting both axons and myelin as well. So in terms of etiologies, again, there are many, I cannot list all of them here. This is a limited list. But the most common, like I say, is diabetes. 60 to 70% of patients with diabetes will develop neuropathy. And if we take all our clinic patients into account, probably at least half of them may be from diabetes as well. After diabetes, other common treatable causes that we try to evaluate for in the clinic, vitamin deficiencies, okay? And I have a few slides about that, but some vitamins when they're at low levels can cause neuropathy. Alcohol abuse, I think is also a common cause of neuropathy. Other causes are always less common. There is something called a monoclonal protein. Basically, these are abnormal proteins in the blood, usually secondary to blood cell disorders. And prevalence of this, or the frequency in which we see these monoclonal proteins in blood increases with age. And most of the times they are benign, meaning they don't mean cancer, but in some cases they can be associated with these blood cell cancers such as multiple myeloma. And those proteins, when they accumulate, they can also deposit in the nerve and cause neuropathy. So we always screen for such a cause, etiology in our workup. Even more rare causes are autoimmune problems, vasculitis, like I say, which is blood vessel inflammation that affects the blood vessels inside the nerves. So it leads to nerve infarcts. Toxins, such as heavy metals and solvents, medications such as chemotherapy, trauma, some infections such as HIV, Lyme disease, tumors with nerve infiltration, kidney and liver disease, so end-stage renal disease, being on dialysis, or cirrhosis, liver failure, chronic diseases can affect the nerves, thyroid problems, and also genetic. So genetic neuropathies are also a big part of our clinic because we are in a specialized center. So how do we make a diagnosis of neuropathy? First, we obviously take a history, we need a history that's compatible with a neuropathy. So the history usually mentions, because the most common causes are going to be types of neuropathy are going to be sensory. The history usually includes numbness, tingling, pain, loss of balance, or a combination of those sensory symptoms I mentioned before. There can also be a history of muscle weakness or atrophy if the motor nerve fibers are affected. So that's not always the case because the most common cause or type of neuropathy is sensory. But some patients have motor involvement as well. We can also screen for autonomic involvement, looking for some other symptoms such as dry eyes, dry mouth, urinary or bladder incontinence or retention, passing out or lightheadedness, standing up or getting up from a chair, erectile dysfunction. Those are different symptoms usually indicative of autonomic involvement of the neuropathy. And then after we know we have a history that is maybe compatible with peripheral neuropathy, we examine, we do a physical exam, a neurological exam. We're going to test sensation, the pain, temperature, vibration, or something we call position sense, so moving the joints in space where the patient is not looking and asking them if they know the direction of the movement. Okay, normally we are patients are supposed to know. You're moving the joint up or down, in any direction. You're supposed to know where your joints are in space. Decreased reflexes, deep tendon reflexes, for example, in the knee, at the ankles, or on the elbow. Weakness, if the motor fibers are affected, there can be also some muscle atrophy or wasting. And balance problems, usually if joint position sense is affected. So we have a history and exam compatible with peripheral neuropathy, but the workup or the diagnostic process doesn't end there. We need to do something called a nerve conduction study and also an electromyography. So this is what we call the Emg test. So when you go to the clinic and they say, we need to get an Emg, they're trying to say, okay, we're gonna do an electrodiagnostic testing of your nerves and muscles. So the Emg test really includes two parts. One is a nerve conduction study, NCS, in which we measure these nerve responses to electrical stimulation. So we use a very small stimulator that gives some electrical discharges to different parts of the arm or your leg to record the nerve responses. So it's not painless, okay, because you're gonna get some shocks, and the pain really is variable. It's obviously depending on the intensity of the stimulus we given to the patient at that point. The intensity depends on the nerve response as well. We try to get the best response possible. So sometimes we have to increase the intensity to very high level to get the best response, especially the nerve is very sick. We have to make sure we are not missing something there. But sometimes even with a small intensity, some patients experience a lot of pain, but I can tell you that most of the times the test is very well tolerated. And this is some figures showing, okay, where we stimulate for some nerves. This is the stimulator. This is part of the stimulator called the cathode. We use 3 electrodes to record the response. This is the recording electrode, reference electrode, and the ground. Then the second part of the Emg test is the Emg itself. Emg stands for electromyography. We're using something called a needle electrode. So it's a small needle. I call it a microphone needle. It's not really a microphone. You cannot sing using that needle, but it makes the electrical stimulus convert into sound. So you can hear the sound in the computer and also look at the waveforms. We are recording, again, the muscle electrical activity. We don't give any electrical stimulation using this needle, okay? There is no injection. It's just a recording of electrical muscle activity. We do have to move the needle inside the muscle to provide, to get a good recording in different parts of the muscle. So the movement of the needle can be uncomfortable. And we get different sounds, different waveforms. They all have different meaning, such as nerve damage, muscle damage, or normal. And we know how to interpret them. We're looking for evidence of nerve or muscle injury. And again, the pain will depends on the patient tolerability. Most patients tolerate it very well. And this is, an example. This is a microphone needle, the Emg needle. This is the ground electrode, and this is, the needle going up inside the muscle. And this is an example of. Let me see this place here. Yeah, so this is an example of a normal Emg, and each of these spikes is one motor unit potential, something we call motor unit potential. So one muscle fiber discharge. Yeah, and we get different views in different parts of the muscle using this needle. So, besides the Emg and nerve conduction study, we also have to do some blood work trying to find the etiology of the neuropathy, okay? If we don't find the etiology of the neuropathy, obviously we cannot try and fix it, okay? There is symptomatic therapy always included, but to try to cure the neuropathy, we have to be able to find the cause. Most patients, the standard testing should include diabetes testing, again, because diabetes is the most common cause. So the best test for that is the two-hour glucose tolerance test. Fasting, you get the first blood drawn, and then you drink liquid containing about 75 grams of glucose, and then you get a 2 hours test again. That's the most sensitive test for diabetes and pre-diabetes. An alternative could be the hemoglobin A1C as well. And then other baseline testing should include B12, folic acid, B6 in most cases, and also something called a serum protein electrophoresis or serum immunofixation, this is better. And this is to check for those abnormal proteins in blood I mentioned before, the monoclonal proteins. So they can be detected using this serum immunofixation or electrophoresis. And in some cases, we also order B1, other nutrient levels, other vitamin or nutrient levels that if they are decreased, they can also cause neuropathy. So not always in all the cases, but we can check for B1, copper. We can also do other extra autoimmune workup and also vasculitis workup, which is looking for this blood vessel inflammation. This depends on our clinical suspicion. Genetic testing can also be ordered in some patients that have family history or have, the exam suggestive of a genetic neuropathy. Important to know is also something called idiopathic. So idiopathic basically means we don't know the cause, okay? So there are patients that have peripheral neuropathy by exam, by history, even by nerve conduction studies. So it's a real neuropathy, you can see it there. But we do extensive workup and we cannot find the etiology. And this is not just common to neuropathies, it's common to different areas of medicine. This includes about 30 to 50% of the cases, especially the patient with neuropathy was older than 60. Okay, so the prevalence of idiopathic causes of neuropathy increases if you are above 60 or 65 years of age. So in terms of other studies, MRIs, including MRI of the spinal cord, of the lower extremities, for example. This is only done in special cases, depending on our clinical suspicion, especially to rule out other mimickers of neuropathy, perhaps. Lumbar puncture, again, something called a spinal tap, in which we may need to get some fluid from the back. That fluid kind of bathes the nerves coming out of the spinal cord, so we can look for inflammation or infectious causes of neuropathies in those some patients. So if we have a suspicion for those causes, then we may recommend to get a spinal tap. Nerve, muscle, or skin biopsy, also in special cases only. Now, some things to remember are the nerve conduction study in the EMG only evaluate something we call a large nerve fibers. And what are those large nerve fibers? Those large nerve fibers are those fibers that have a lot of insulation around them. Okay, they're covered with a very, very thick cover of myelin, this insulation on the nerves. Those are the large nerve fibers. So the nerve study in the EMG only evaluates large fibers. However, not all the sensory fibers are large fibers. We also have small fibers, the fibers in our body that carry a lot of pain and temperature information. They are all small fibers. So if the involvement of the sensory neuropathy is only affecting the small fibers, then your nerve study will be normal because those small fibers are not being tested by the nerve study, okay? So there's a group of people, especially for example with diabetes, especially at the very beginning of neuropathy, that may have a normal nerve conduction study and EMG, and they still have a neuropathy, a real neuropathy. It's just a small fiber neuropathy that cannot be diagnosed with this test. To diagnose those small fiber neuropathies, we may need to do other tests, such as skin biopsy, for example. Yeah, so if the nerve study and EMG are normal, we're gonna consider possibility of a small fiber neuropathy. Okay, these small fibers, again, are in charge of pain and temperature sensation. And possible diagnosis should include, in those cases, skin biopsy or autonomic testing. Autonomic testing because the autonomic nerve fibers are also very small fibers. So skin biopsy, again, not done in all the cases, but only for a small fiber neuropathy. The procedure includes taking a small punch biopsy, usually at the skin of the lateral side of the leg, 10 centimeters above the ankle, or the thigh, about 20 centimeters from the hip bone area. And then the pathologist will look at the skin under the microscope and count the number of nerve fibers in the skin. If the number is below a certain, range for age, then it is diagnostic for a small fiber neuropathy. Now let's talk about some etiologies of neuropathy. Okay, some common etiologies. Alcoholic neuropathy. So the mechanism of alcohol causing neuropathy may include a toxic effect of ethanol, and also some patients that alcoholics or have alcohol abuse, they can also have low vitamin B1 levels because they may have some degree of malnourishment, and if you have low vitamin B1 levels or other B vitamins in the low range, that can also cause neuropathy. The alcoholic neuropathy will affect mostly the axon itself, so the nerve itself, the copper wire I talk about. So the damage can be very severe, can cause a lot of pain, numbness, and weakness. It can also affect the autonomic nerves, by the way. So the blood pressure, sweating part, the bowel and bladder part can be affected in some cases of alcohol-related neuropathy. So now, how much alcohol you really drink you really need to have neuropathy? I mean, it has to be a significant amount, okay? So drinking a glass of wine every day is not gonna do it. So one standard drink contains roughly about 14 grams of pure alcohol, which is found in about 12 ounces of regular beer, 5 ounces of wine, and about 1.5 ounces of spirits. And in most neuropathy studies require the regular consumption of more than 100 grams of alcohol per day for more than 3 to 10 years. So we're talking about, quite a bit frequently, and long duration as well. Up to 67% of alcoholics can have neuropathy, and half of them may be subclinical. So they don't know they have it. They may go to the doctor for something else, for memory problems that can also be commonly seen in people with alcohol. Or, they go to a primary doctor for a liver problem, some other things, and yeah, they have neuropathy. And again, neuropathy development may correlate with duration of the intake, okay? So 16 versus 9 years, obviously longer duration was more common, and also the amount of alcohol use. This is, by kilograms ethanol per kilogram of body weight. About 41% of patients that consume more than 15 kilograms of alcohol per kilograms of body weight over the lifetime met criteria for neuropathy. This represents about 300 milliliters of 86% whiskey per day over several years in a regular man. So it's it has to be a good amount. Diabetic neuropathy. This is usually seen in people that have long and standing diabetes, especially if it's being poorly controlled. Okay. Now, one thing to remember is there is a term called pre-diabetes. Basically, you have glucose intolerance, but you don't meet the criteria for diabetes. But people with pre-diabetes can also have neuropathy, usually a small fiber type. Okay, most pain, burning sensation, hot sensation, cold sensation. That can be seen in pre-diabetes. Like I say, 7% of US population have diabetes, and about up to 70% of them may develop neuropathy at some point in their lifetimes, and significant pain up to a quarter of patients with diabetes. It can affect any nerve type, sensory, motor, and autonomic nerve. So the most common form is distal. Okay, so starting in the toes with numbness, tingling, pain, different sensations, and then it slowly moves up. It can affect the hands eventually after many years. Treatment. So there is no good way to cure diabetic neuropathy, and I have a couple other slides about that, but obviously focusing on a good glucose control is the best, okay? There are some studies that glucose control improves diabetic neuropathy in the long term. But the treatment, most of the times, is going to focus on symptomatic therapy to control the sensory symptoms, especially the positive sensory symptoms, and the pain, the tingling, burning, hot and cold sensation. So if you were to have a patient with diabetes that gets cured of the disease, then depending on the degree of nerve damage the patient had, the time to recovery may be a few months or years. Patients with diabetes have a lot of axonal loss, a lot of nerve damage, or severe nerve damage, the recovery may be incomplete, even if the diabetes is cured. So that's something important to remember. So you have to focus on glucose control very early on, because once you have a lot of nerve damage, even if you control with glucose, it will just not recover completely, or it will take a long time to do so. So diabetic neuropathy can also affect other nerves, okay? So it's the most common cause of neuropathy, and also is the one that has more variety of manifestations. It can cause double vision, because some of the eye movement muscles will be affected with the neuropathy. Carpal tunnel syndromes, common presentation, something called plexopathy. So it will be a damage, usually with a lot of pain, and the nerves in one limb, usually in the shoulder or in the groin area. So you have the shoulder nerves affected, and your whole arm may go weak or numb, or a combination. And the same, if the groin area is affected, the whole leg may be affected. In some cases, could mimic shingles type of pain, without a rash, obviously, but it can cause this very intense pain. It can cause severe blood pressure fluctuations in some cases because of these autonomic blood pressure fibers being affected. And if patients with diabetes have autonomic neuropathy, then that will increase mortality. B12 and neuropathy, it's another common cause. B12 deficiency is another common cause of neuropathy. Our daily requirement is a very small amount, only 2.4 micrograms per day. So most patients, if they have a healthy diet, don't have, a B12 deficiency. So B12 is present in meat, eggs, poultry, and dairy. But a risk of B12 deficiency is present in vegan diets. People with gastric bypass, because part of the B12 is metabolized in the stomach. Proton pump inhibitor medications, so basically medications to reduce the acid in your stomach. You need acid to metabolize the B12, to absorb B12. And metformin use in people with diabetes, for example, Crohn's, celiac disease, etc. It will present as a length-dependent process, usually affecting the lower extremities first, similar to diabetes, but it can also affect the spinal cord. Okay, so that's important, because the neuropathy may recover better with supplementation, but if you have a spinal cord injury from B12, it may not recover completely. So the treatment is going to be B12 replacement, usually intramuscular injections, but also can be high doses orally. Now, it's important to remember, you have a B12 deficiency, unless you are vegan or you were really malnourished, weren't eating for a different reason. This probably indicates some degree of malabsorption. Okay, so your stomach or your gut is not absorbing the B12 it's supposed to, so you probably need supplementation for life, either shots or just take an extra supplement, daily. Common mistake is you have low B12, you start taking the supplements, and then the B12 obviously goes back to normal, and then you stop the supplement, and then you have neuropathy again, because obviously the B12 is going to drop again. B12 levels being low can also cause anemia and memory loss, by the way. Folic acid, this again present in green vegetables, dried legumes. So requirement very small amounts, only 600 micrograms. Can also cause deficiency, can also cause neuropathy, usually a distal lower extremity neuropathy, symmetric. It can also cause anemia, memory loss, spinal cord problems, very similar to B12. So we always screen for that. B6 is interesting. So B6 is also called pyridoxine. The requirement daily is about 2 milligrams per day. Now B12 and B6 is interesting because deficiency will cause neuropathy, usually a sensory and motor, affecting the lower extremities predominantly. But toxicity, so you take too much B6, it can also kill the nerves. So it can cause damage to the sensory cells next to the spinal cord, and it can cause severe sensory loss and balance problems. I mentioned that because it's common for patients to use a lot of B6 supplements. Sometimes they have carpal tunnel or other things, and you have to be careful that you're not getting toxic levels from it. Immune causes or inflammatory causes of neuropathy indicate an autoimmune process. The two most common causes of autoimmune chronic neuropathies are something called CIDP, which is an acronym for chronic inflammatory demyelinating polyneuropathy, and MMN, multifocal motor neuropathy. This is only motor, meaning only affects the muscle fibers and muscle weakness and muscle atrophy. So in some cases can be confused with ALS because of the muscle weakness and muscle atrophy with normal sensation. So we've seen some cases like that in the patients diagnosed with ALS, actually they have multifocal motor neuropathy. And the treatment in these cases includes immunosuppression or immunomodulation. There are some medications called IVIG, for example, or plasmapheresis. This is like a washing out of the blood. And PO steroids such as prednisone can also be helpful in some cases. And in these types of neuropathies, we usually require a spinal tap, for example. Inherited neuropathies. So these are genetic causes, and multiple genes responsible, okay? More than 100 genes that can cause neuropathy. In our clinic, these conditions are called CMT, which is eponym, Charcot-Marie-Tooth disease. CMT means it's a genetic type of neuropathy. Like I say, more than 100 types of them. These patients usually have difficulty with running, sports, or military activities. Some of them may have diagnosis early on of polio, but they actually have neuropathy. And they have difficulty walking on heels and toes. They may have some types of foot deformities. These we call, high arches, pes cables, and also hammer toes. They may have atrophy in the leg muscles, and also claw hands due to atrophy in the intrinsic, the muscles between the fingers. These neuropathies are characterized with very, very slow progression, so many years' time. Unfortunately, none of them have a cure. Okay, so the treatment in those cases is very supportive. So I mentioned this before, so there's something called idiopathic neuropathy. So after extensive workup, still about 30 to 50% of the cases, especially older than 60 or 65 years of age, will be idiopathic. We are left, still have it's a real neuropathy, but we can find a cause. In those cases, usually the symptoms are sensory in lower extremities, on the feet. The progression is very slow, usually over many years. And the treatment includes symptomatic therapies with nerve pain medications or braces, depending on the symptoms. So what treatment options do we have for neuropathy? Okay, almost all of them, all the cases, regardless of the etiology, require symptomatic therapy. These include what we call neuropathic pain medications. The different agents, including seizure medications such as gabapentin, Lyrica, antidepressants such as amitriptyline, nortriptyline, Cymbalta is commonly used as well for diabetes neuropathy. Capsaicin cream, lidocaine cream, tramadol, some other analgesics. Physical therapy is important, exercise, and assisted devices such as orthotics, braces, foot care, especially in people with diabetes or severe sensory loss, always monitor for any skin bruising or breakdown because it can lead to ulcers and infections. So in diabetes, controlling blood sugar level may prevent further nerve damage or at least slows down the progression. Vitamin deficiencies, obviously vitamin replacement can stop or partially reverse neuropathy. Again, it will depend on the degree of nerve damage. Autoimmune causes are the most treatable ones, but again, depending on the degree of nerve damage the patient had before diagnosis. And exercise in general, will reduce pain, improve overall health and mood, and it has been shown to be beneficial for symptomatic therapy as well. There are electrical devices such as TENS unit or different types of electrical stimulation that can also be have been shown to be helpful to reduce nerve pain in some patients. Okay, I mean, this is not a magical cure, I think. I will say maybe half of my patients think this has helped them at some point. And I think that the problem is when patients try this when the neuropathy is already very severe and it's very hard to treat with any alternative. Smoking, nicotine increase pain perception. So we encourage patients to stop smoking if they can. Like I say, alcohol, it can be toxic to nerves. So if the patient is a frequent drinker, that will always help with recovery. Healthy diet to minimize nutrient deficiencies. Avoid excess of vitamins such as vitamin B6 because it can be toxic to nerves. And again, just to reinforce the point that degree of improvement will depend on the extent of nerve damage and also the duration of the neuropathy. This is a slide with some alternative medications or supplements that have been tried for peripheral neuropathy, usually people with diabetes because it's the most common neuropathy, but I think it can be applied to any neuropathy that causes pain. Alpha lipoic acid as an antioxidant. Some studies show the benefit in diabetic neuropathy up to a dose of 600 milligrams per day, usually intravenous, but we don't have that here in the US, so we have oral supplements that people can try. Turmeric, a small study, 80 milligrams per day, used for 8 weeks, decreased pain. Again, never the pain went to zero, but there's some reduction in pain intensity compared to placebo. Acetylcarnitine, again, up to 3 grams per day. Vitamin D levels, so low levels have been associated with some neuropathy and people with diabetes in small studies again. So supplements could benefit, neuropathy symptoms in some cases. These are different doses that have been tried in people with diabetic neuropathy. Folic, again, we mentioned this, folic deficiency can cause neuropathy. But even in people without deficiency, supplementation 1 milligram a day for 16 weeks improved the nerve conduction values in a small group of patients, 75 patients. Omega-3 fish oil improved pain and was supplemented for 3 months. In a pilot study, I believe this was 40 patients perhaps. Methylcobalamin, which is a B12 supplement, 44 patients versus 46 on placebo that have a low normal level of B12. And we're using metformin to reduce pain and improve nerve study results as well. And it was supplemented for 1 year. Exercise, the different studies showing the effect of exercise and pain of different etiologies, including neuropathic pain. So moderate intensity aerobic exercise, we're talking about biking, swimming, a little jogging. Doesn't have to be that intense, so they only need to have 40–60% of heart rate reserve. So, 80, 100 beats per minute. 3 times a week, average of 90 to 100 minutes per week. So it doesn't have to be daily either. Could reduce the pain from the that'll be all. So I'm ready to try to answer some questions. Thank you.
All right. So I'm going to ask you to stop your slides, and we have a lot of questions. I'm going to go ahead and get to them. Let's see. Our first question I want to ask is, can you describe what good glucose control means for a diabetic?
Well, the goals, I think, is to get your hemoglobin A1C less than 6. So the diagnostic criteria for diabetes is hemoglobin A1C less than 6.5. But like I mentioned, pre-diabetes it's also being associated with neuropathy. So my opinion, to getting your glucose, your hemoglobin A1C less than 6, which wouldn't qualify as pre-diabetes, would be optimal. But the closer you can get it to normal, the better it will be. The more uncontrolled it is, the worse it's going to be. So if you A1C was 15 at some point and right now it's 8, so that's better. Okay, it's already elevated. It's still elevated, but it's better than if it was 15.
Okay, sounds good. Is TENS helpful for the CIDP?
So a CIDP, like I mentioned, is autoimmune neuropathy. Okay, so the immune process, the immune system is attacking the nerves. In some cases, some antibodies have been discovered. So TENS unit, B12, all these things I mentioned in my couple of slides at the end, those are symptomatic therapies for pain. To my knowledge, there have been no studies of TENS unit in CIDP pain, but it has worked partially for other types of neuropathic pain. So it will be potentially a symptomatic treatment, but not a curative treatment. So CIDP is an autoimmune disease. So you need to fix the autoimmune process to, in the end, cure the neuropathy or control it at least. Okay, so it will, treat the symptom, but the neuropathy may continue to progress over time. So you need to focus on the autoimmune part.
Okay. I have a question. How do you determine if your symptoms are related to a pinched nerve, like in your neck?
Okay, so yeah, we suspect a pinched nerve. and pinched nerves are common, okay? People with neuropathy can also have pinched nerves. So but we suspect pinched nerve either is neck or lower back pain radiating down the arm or down the lower extremity, okay? What we call sciatica, for example, that's usually from pinched nerve. You know, turn your head to one side or the other, and sometimes, yeah, it's a shooting pain down my arm, doctor. It goes to my finger or my thumb, it goes to my elbow. That may be a pinched nerve. So pinched nerve, and by definition, by medical definition, it's still a neuropathy, but it's a neuropathy secondary to a radicular, a root problem, a pinched nerve. But you know, the treatment will be different. Treatment usually involves physical therapy, neuropathic pain medication, so like gabapentin, Lyrica, things like that. And then if the pinched nerve is very severe, causing a lot of deficits, such as weakness, wasting, you know, intractable pain that you cannot use the arm or the leg, then you need surgery.
Okay, thank you. Someone wants to know, can therapies help, like massage, can they help neuropathy, or do they just relieve pain?
Again, those are all symptomatic therapies. Okay, I didn't mention massage therapy here, but I believe yoga, for example, and other exercises similar to yoga, or meditation, mindfulness, I think it's called. It can also have been shown to reduce pain perception. Okay, but it hasn't been proven to improve the nerve, you know, amplitude, the nerve recovery.
Okay. Can you discuss stem cell treatments for peripheral neuropathy? I had a couple questions about that.
Yeah, to my knowledge, that hasn't been shown to be beneficial. I'm not that well versed on that, obviously, but it's not FDA approved. There are stem cells trials being done for ALS, for example, motor neuron disease, but that's a different condition. But no, to my knowledge, not for neuropathy.
Okay. Does peripheral neuropathy cause this random cramping that I might have?
Peripheral neuropathy can cause cramping. It's not the only cause of cramping, but it can. So you know, the other causes of cramping, muscle conditions, just muscle fatigue can cause cramping. Electrolyte problems, you know, low potassium or magnesium can cause cramping. So there are different causes.
Okay. Is central pain syndrome a form of neuropathy from a thalamic stroke? Yeah,
central pain syndrome is different. So neuropathy, even as defined as a medical term, you know, can affect any nerve damage. Usually refers to nerves from the peripheral nervous system, from the spinal cord down to the skin, I guess, to your muscle. So central pain is secondary to thalamic strokes or thalamic injury. It's more like a perception of pain. Even though there is no nerve injury in your arm and your leg, your body feels like, okay, there's something there, it's hurting. And because the body representation of that limb in your brain is damaged. So if the stroke affected, you know, the right side of your body, so the right side, the left side of your brain that represents the right side of your body feels the pain. And the treatment, unfortunately, is very difficult in those patients, but we use similar medications. We use, you know, gabapentin, Lyrica, and try to work it out that way.
Okay. Have you been able to help people who have neuropathy from lightning injuries? I have numbness on the right side of my body.
I never had a case of lightning injury causing neuropathy. So I guess I'll say no, but depending on the degree of injury, you know, if you have permanent nerve damage, it may just be difficult, you know, for the nerve to recover. It will depend on where the injury level is. If it's in the spinal cord, again, it's probably permanent. If it's more peripheral, you know, the arm or the leg, there can be some surgical corrections, perhaps, if like nerve grafts and things like that can be attempted. It just depends on the type of injury.
Okay. I have a question. I've suffered neuropathy for 20 years in my feet, no relief. I'm not diabetic. I don't know what caused it, but I'm now suffering from COVID pneumonia and have developed neuropathy in the tips of my fingers. Is this a side effect that's common of COVID-19? And are there any treatments to alleviate it?
So if I understand correctly, that neuropathy is 20 years in the feet and now it's in the fingers?
Yes.
Right? Okay. Yeah, I mean, COVID-19 can cause different neurological complications. Some of them have been described as neuropathy. Some of them are GBS-like this acute neuropathy. I don't know if that's the presentation that, you know, the question refers to. If the patient, was in the ICU, there's also ICU neuropathy. There are other complications. Just being very, very sick can cause neuropathy. Again, it will depend. I don't know what else to say.
Yeah, seems to be new medicine we're still figuring out as we go. So another question, can sensory or muscular peripheral neuropathy be confused with other types of muscular disease?
Well, by symptoms, yes, I guess, to a certain point, okay? If you have numbness or tingling, neuropathy is not the only cause, okay? It's one of the causes. It all depends on the history and our exam findings, our suspicion. So differential, again, will be pinched nerve, because that can also cause numbness and tingling. If we keep moving upwards, the nervous system, it could be a spinal cord problem, a tumor, it could be MS, multiple sclerosis, it could be strokes. So yeah, so there are different causes that can produce numbness and tingling. The same for weakness. If you have weakness, it could be peripheral neuropathy, it could be ALS, it could be a tumor, it could be trauma. It just depends on our history and exam findings, yes.
Okay. Could you please discuss neuropathy after chemotherapy? I'm curious to know, is it going to improve over time, the symptoms that I'm having?
Yeah, so neuropathy after chemotherapy happens especially if the patient has received clotting agents or Taxol agents commonly associated with neuropathy. I'll say that the recovery, again, like in all neuropathies, depends on the degree of nerve damage, okay, the nerve axonal loss. So if the nerve itself has been killed, as in all chemotherapy agents, they usually are affecting the copper wire itself, so they're axonal. So if it's very severe, the degree of recovery is going to be minimal, probably incomplete with time. But there's always some degree of recovery if you haven't received more chemotherapy. The problem is that even after stopping the chemo for a few months, even up to a year, I think, or a year and a half, the neuropathy can continue to progress from chemotherapy. Okay, there is a residual effect of the chemo on the nervous system, so it still keeps progressing, and eventually will stop, and then you start recovering. But the recovery I've seen is usually incomplete, especially if the damage has been very severe. So we have to focus on obviously avoiding other damaging agents to the nerve. So alcohol, if you have diabetes, try to keep it under very, very, very good control. Check all the vitamin levels to make sure they're not low, to prevent more nerve damage. And then all these other symptomatic therapies I mentioned. And some of the supplements such as B12, folic acid, antioxidants like that, even B6 low doses, in some cases have been shown to be beneficial for symptomatic treatment of chemotherapy neuropathy as well.
Okay, so I'm gonna ask a question. I always hear about burning feet. My sensation is that I have cold feet that gets worse during the day as I'm on my feet. It gets debilitating by the late afternoon. How common is the freezing and feeling, and what can I do to alleviate it?
Yeah, so cold feet could be a sign of neuropathy. It could just be also peripheral vascular disease, I guess. That would be the other thing I could think of. It could be a sign of small fiber neuropathy. Again, the treatment or alleviation could come from finding the cause, right? If this is from prediabetes, focusing on treating that. If it's another autoimmune etiology, maybe the beginning of Sjogren's or other things, it would fix that. It could lead to improvement. Otherwise, it's just symptomatic therapy. Sometimes gabapentin lyrica helps. Patients that have, extremely cold feet, they can use warmers or stockings to try to keep them warm as well.
Okay. Someone asked, I have neuropathy as a result of a spinal injury. After surgery, I also started to have leg cramps almost every morning and every night. Are the cramps related to my neuropathy?
Yeah, so spinal cord injury, I guess it will depend. If it's a spinal cord trauma, for example, or infarct, and then the patient has lost mobility in the lower extremities, by definition, maybe it wouldn't be a neuropathy such as I describe it here, because neuropathy will have to be from the spinal cord out. But obviously you lose control, so still the nerves in the spinal cord are affected. And yeah, people with spinal cord injury can have spasms, okay? Spinal cord spasms, that's common in spinal cord tumors or MS or even spinal cord injuries. And the treatment for that is muscle relaxants. I didn't mention that here, but baclofen, and we have other sort of muscle relaxants that can be helpful for spinal spasms.
Okay. I got a couple questions about the drug gabapentins. A couple people wanted to know, I'm taking like 900 milligrams a day. Is that too much?
Again, the maximum dose in adults is up to 3,600 total a day. So 1,200 milligrams 3 times a day. So I guess it will be on the lower side. But our dose limiting really is depending on adverse reactions or side effects.
Okay. Yeah. Someone also says, I take gabapentin, but I don't see any change with it. You know, what would my next step be? I already take a B12 supplement.
Yeah, so if it depends, again, depends on what the gabapentin is being given for. I always try to be clear with my patients. These neuropathic pain medications are for the tingling and positive symptoms, really. Tingling, a lot of this burning sensation, maybe the cold sensation and things like that. What we call paresthesias, abnormal feeling. It's not much for the numbness. So the numbness is a negative symptom. And that we cannot fix because a negative symptom is from lack of function of the nerve. The gabapentin is not going to make it function because the nerve is damaged. The gabapentin reduces the nerve misfiring, so it can attack the positive symptoms, but not the negative ones. So if the patient has mostly numbness, but no pain, no tingling, then you don't need gabapentin because the gabapentin doesn't expedite nerve recovery. Your own body does the nerve recovery.
Okay, someone asked a similar question about that. Can small fiber damage repair itself or does it just get worse?
Again, yes, it can, all nerve damage has the potential to repair itself depending on the degree, the extent of damage, the duration of the injury. So the answer is yes, it can.
Okay. I have another question that my mom is 96 years old, has neuropathy in her fingers on both hands and has dizziness. She has limited mobility and walks with a walker. Would you suggest that she sees a neurologist?
Yes. Yes, I would suggest if she has, looks like she has different type of neurological symptoms. The dizziness could be also related to inner ear problems or blood pressure problems, but could also be neurological. So yeah.
Okay. You talked about some of the kind of, maybe I'm going to call it over-the-counter solutions, but we got a couple questions about, are there topical sprays? How do socks help and things like that? Are there some over-the-counter things that people could try without, too much effort to try to improve things?
Yeah, so some over-the-counter, some of the medications I mentioned are over-the-counter, the supplements, but also lidocaine cream, for example, that's over-the-counter. There's a prescription type that is 5%, but the over-the-counter one is 4%. So it's just 1% less than the prescription one. So it's good enough. And there are lidocaine patches as well. So those can be used in the lower extremities, to reduce the tingling, the burning sensation 3 or 4 times a day. Always being careful, wash the hands after using them. So you touch your eyes, don't get numb or your face gets numb. Capsaicin cream is the other one. Capsaicin is very irritant to nerves. So it will increase the burning. So that's the only problem. So sometimes you have to combine it with lidocaine. So lidocaine numbs the nerves. So you use lidocaine first and then use the capsaicin on top to minimize the burning. After about 3 to 7 days of use of capsaicin, though, what the capsaicin does is kills the nerve terminals. So I guess you can say kills part of the nerve, the very end of the nerves. So you stop feeling the burning because the nerve terminals are gone. The nerve can regrow again, but it can, the effect can last a few days. But again, you have to combine it with lidocaine because otherwise I think the burning may be too much.
Okay. Someone wants to know, I have kyphosis. I'm wondering, can this contribute to my problems? I'm not a diabetic.
Probably not. I mean, I guess problems, neuropathy probably. I don't know what problems the question refers to. If it refers to neuropathy,
yeah, I assume so.
Probably not, unless the kyphosis is so bad that it will cause spinal cord compression. Then yeah, the spinal cord compression will cause other things, but most likely not.
So someone says, myself and my father are very healthy. We both had toe numbness for many years, and he's had it since he's been, younger. And they want to know, is there treatment that can help for this hereditary neuropathy?
No, there's no cure at this moment for the hereditary neuropathy. There are some clinical trials depending on the type of neuropathy, genetic neuropathy you have. It was one of the most common ones. Yes, there's probably a trial around the US. We have genetic testing available that is sponsored by different companies, and it's free. So that's why I think it's important for patients to come to clinic and get evaluated. And it is genetic. We can do genetic testing and confirm. If you have one of the most common types, then there may be a clinical trial.
All right. A couple just like questions about causes. Can it be caused by Raynaud's disease? Can neuropathy be caused by that?
No.
Okay.
Raynaud's disease is a vascular phenomenon, but some neuropathies can cause Raynaud's disease, actually. Like a small fiber neuropathy can be associated with Raynaud's disease in some cases. Or multiple myeloma can cause Raynaud's disease and also cause neuropathy, so they can have common causes. All
right. Could receiving spinal anesthesia for a knee replacement cause neuropathy?
Well, depending where the area of anesthetic was placed, I guess it could damage the nerve and cause neuropathy that way, like spinal blocks or shoulder blocks for brachial plexus blocks for arm surgery can cause neuropathy, depending if the anesthetic was injected directly in the nerve. Maybe that's what the question is asking, but yeah, I guess it can.
Okay. Is there a difference in the pain caused by gout and neuropathy? I'm trying to decide if I should treat my gout symptoms and therapy or go see a neurologist first.
Well, gout pain is usually localized to the joint, usually the big toe joint. So it's different pain location and also type. It's more like joint pain. So it will be different. So I guess it depends on the type of pain you're experiencing.
Okay. Well, that is about all the time we have questions for today. I want to thank everyone for joining us and thank you so much for your time. And if you're watching, we're going to send out a link to the recording. So if you wanted the slides or anything like that, I'll send that out and those will be closed captioned as well. So it'll take me a few days to get those out, but you should receive them shortly. Okay. Thank you so much for your time today.
Thank you.